In today's video, we will discuss about upper GI bleeding. Imagine you are the casualty house officer and the patient is brought with vomiting buckets of blood. How will you attend to this patient? Well, first in line should be to assess the patient's airway, suck out any blood or vomitus in the mouth, and if the patient is unconscious, consider an oropharyngeal airway. Then connect the patient to the cardiac monitor, including saturation probe to monitor the oxygen saturation. Check the blood pressure, pulse rate and respiratory rate. Keep the patient in left lateral position to prevent aspiration and a head low position to increase the venous return. Then begin resuscitation of the patient by establishing an intravenous access with two large bore cannulae, preferably 14 or 16 gauge, the forearm aspect, and take blood for grouping and direct testing. At the same time, reserve minimum of 4 units of blood. Several blood investigations should be ordered at this time. A full blood count, PT-INR, serum electrolytes and creatinine levels. Resuscitation is carried out with 500 ml of 0.9% saline via each cannula, and we could give up to 2 liters of saline, keeping in mind if there is a need for large volume resuscitation, Hartmann's solution would be the better option, considering its similarity to blood plasma, and also normal saline could lead to metabolic acidosis given in large amounts. Also, we have to look out for and correct any coagulopathy with fresh frozen plasma, especially in patients with cirrhosis and bleeding, since they are lacking coagulation factors. Then, catheterize the patient and maintain an input-output chart while monitoring the vital signs, blood pressure, pulse rate, respiratory rate, oxygen saturation, and urine output, which is the best indicator of adequate fluid resuscitation. We have to inform the ICU if the patient's condition is worsening. And finally, we can take a quick history and examine to look for the cause. So what are the causes of upper GI bleeding? Two of the most common causes are variceal bleeding and peptic ulcer disease, which we will discuss in detail today. We can categorize the causes of upper GI bleeding into esophageal causes, gastric causes, duodenal causes, and other causes. The esophageal causes being esophageal varices, Mallory-Weiss-Ster, reflux esophagitis, esophageal cancer. The gastric causes would be gastric ulcer, gastric cancer, and acute gastritis. Under duodenal causes, we have duodenal ulcer, and other causes would be dengue fever, angiodysplasia, hemangioma, coagulopathies, congenital, acquired liver disease, and inadequately controlled warfarin therapy. So let's see how we can clinically differentiate the two most common causes. In peptic ulcer, there's a past history of dyspeptic symptoms such as bloating, heartburn, nausea and vomiting. Whereas in variceal bleeding, there's past history of alcohol consumption, hepatitis together with jaundice. In peptic ulcers, there's usually a history of smoking, alcohol abuse, long-term NSAID use. And on examination, you would not expect anything specific with peptic ulcer disease, whereas variceal bleeding would be associated with peripheral stigmata of chronic liver cell disease, such as parotid swelling, spider nevi, Palmer erythema. So let's dig a little deeper into this case scenario to understand the situation better. How can a peptic ulcer cause heavy bleeding? The common site of a peptic ulcer is the first part of the duodenum, and the gastroduodenal artery runs posterior to this part. And when the ulcer erodes into the gastroduodenal artery, you can imagine. Now that we have successfully managed the emergency, what are the definitive management options for this patient? If the patient is having variceal bleeding, then we have to start drugs to reduce the bleeding by constricting the blood vessels. For that, we use intravenous terlipressin or vasopressin. Terlipressin is the better drug because it's more specific for the splanchnic circulation, whereas vasopressin can cause generalized vasoconstriction and as a side effect can cause cardiac vasospasms. We also have to start a drug to reduce the gastric acidity to facilitate the clotting of the blood from the bleeding sites. Therefore, we use intravenous omeprazole infusion. Then, We have to call the gastroenterology lab for emergency endoscopy once we remove any dentures and exclude allergy for local anesthetics. The definitive endoscopic treatment would be sclerotherapy or banding. Usually banding is preferred over sclerotherapy because it can damage the adjacent mucosa, increasing the risk of perforations. And if the patient is still bleeding after banding, we can repeat the endoscopy once more. Failing which, interim measures like balloon tamponade with sense-taken Blakemore tube to buy time for more invasive options like TIPS, transjugular intrahepatic portosystemic shunt, or esophageal transection, where a part of the lower esophagus is removed. But the problem with shunt procedures is that it could precipitate hepatic encephalopathy because it bypasses the detoxification carried out in the liver. If your initial diagnosis was peptic ulcer disease, there's no need for splanchnic vasoconstrictors. The endoscopic options are adrenaline injection to the ulcer base, bipolar diathermy, clipping or argon plasma coagulation of a visible bleeder, and the surgical options are underrunning of the ulcer, left gastric or gastroduodenal artery ligation, partial or total gastrectomy. And finally, few points on secondary prevention. Depending on the etiology, long-term propranolol to reduce portal hypertension in cirrhotic patients, making sure to exclude bronchial asthma. Interval banding or sclerotherapy for varices. Anti-ulcer treatment for peptic ulcer disease by proton pump inhibitors, H. pylori eradication with antibiotic therapy, avoiding NSAIDs, and stopping smoking and alcohol. Please leave a like and subscribe if you like this video. Feel free to comment your questions and suggestions. Until next time, have a nice day.